आमन्त्रित गरे सँगसँगै I would like to invite other speakers of this plenary session to the front as well. So Professor Siripen to also come in the front and be seated, but I'll shortly call you for your presentation as well. Mr. Achyut Raj Pandey to also be seated in the front. Achyutji, please. And then Professor Dr. Shivaraj Adhikari, I'd like to also invite you and be seated in the front along with Dr. Band Appelt. I cannot see him, but he will be joining shortly and we'll have him in the front as well. With this, I'd like to quickly move to the other session. The other session is on the experience sharing of Thailand. So the title of the presentation is Thailand's Healthcare Financing, Pathways, Performance, and Future Directions. I'd like to again invite Professor Siripen for your presentation, please.
Okay, thank you for for my opportunity to share with you for Thailand's healthcare financing, pathway, performance, and future direction within 15 minutes. I'll be in from 30 minutes, but anyway, 15 minutes I will be in quick. So for my sharing on this is our historical development of healthcare system in Thailand. You can see that at the beginning of 1945, we start with Yusufi. And then with that one, you can see along of this, no? At the left side, that is on, we call it like supply side. The way the health system in Thailand be developed, we have National Health Plan. Unfortunately, National Health Plan of Thailand is developed by the Ministry of Public Health, so they involve only public sector. However, in Thailand, public provider account for about 80%. Just count by number of hospital beds. 80% belong to the public. That means Ministry of Public Health is a main of the healthcare provider in Thailand for public sector. And then the rest of that 20% belong to private sector. Compared to Japan or South Korea, that is about 90% of private and 10% of public. But Thailand is 80% of public and 10% of private. When we start on that, you can see that when we, in the year 1972, we be able to build community hospital at our district level. And we have health center in every sub-district level as well. So with that one, we mean that we have infrastructures already before we start our universal health coverage scheme. Along of that is we establishment of prepayment scheme, like for the low-income card, LAC is low-income card, and with the community health fund, with social security scheme, and CS-MBS, that is Civil Servant Medical Benefit Scheme. Government try to limit number of civil servants. Luckily, I'm the civil servant status. I be in beneficiary of the CS-MBS until I die. Meaning that there is no support that you retire, you still enjoy with this program of CS-MBS. But right now, because government try to limit number of civil servants, right now many of the government work for the government office is that we call is like government employees. And the government employees will be entitlement to the social security scheme. look at that. Thailand never used social health insurance. We use social security scheme. Even with the UC, it's not insurance. UC in Thailand is what is a security scheme as well, right? Because of the social security scheme of Thailand, the benefit package will be for both health and non-health benefit. Social security scheme of Thailand is Thai contribution from government, employer, and employee. But government will contribute only for health benefit. Non-health benefit is just only for employer and employee. But you see, use general tax base. You can see that we have start from establishment of prepayment to the expansion of prepayment scheme, right? This one is on expansion. Expansion meaning that from low income card to be medical welfare scheme. Actually, it's because of in that time, government said that people might not want to be called low income. So they said to be from low income card to be medical welfare scheme. And for the remain with social security scheme, CSMBS, community health fund moved to be public voluntary health insurance. And public voluntary health insurance, in that time, we call health card scheme. But that is the fund is from the government only. I still remember by that year, I did not work for Ministry of Public Health, but I do research for them for the public voluntary health insurance scheme or health card scheme for almost 10 years. From that, I work throughout the country in almost every province, just only to try to talk to the Thai to understand that they need to pay something. In that year, public voluntary like health insurance, only that year, insurance, meaning that is health card they have for 5 members in the family, and government will pay for 1,000 baht, but the household pay only 500 baht per year, right? They learn about that, but unfortunately, we have economic crisis in the late of 1997, so-called Tom Yam Gung crisis. You may heard Tom Yam Gung is a Tom Yam, right? You have that. It's mixed everything. No one knows why we have that crisis. And then in that, people lose their job. It's like window of opportunities for a new party to just campaigning for universal health coverage scheme. Because people lose their job, they not be able to pay for their health care if needed, and then campaigning. That is the first time that we involve politics in health. So now people just said that politics should be taken out of health because health is so technical, right? And health is just with life and death, right, of a population. But however, you see in Thailand never be able to start without politics. And this is the first time when we start, meaning we change from supply side mechanism, budget, right? Retrospective is budgetary, like through the Ministry of Public Health, and Ministry of Public Health are both as a provider and purchaser, right? But we change from supply side financing to demand side financing. That means capitation payment, right? From input-based budget to output-based financing. You can imagine that when we start, how can we control the demand? And we expect in that time, why in that idea is like this. For Thai, we think that it's the same, right? At the end, it's pay for healthcare consumption, other consumption, and with the government spending. So in that, we've seen that for the insurance, it's just only that you have social insurance contribution, but for the tax base, we just have enough healthcare budget. So we use with the tax base scheme in that year. And this is just only for a public side. It's just from the uninsured health card scheme, medical welfare scheme, to be 30 baht co-pay, exempted co-pay, and now UHC. 30 baht become like voluntary. It's like you donate money when you go to a public provider. Now there is no 30 baht anymore. It's voluntary. So you can see that this is on our in historical development for this group. You can see that now private formal sector belong to Workmen Compensation Fund. That is, the illness is not related to work. Employer need to fund, right? That collect the premium from employer only. Social Security scheme, that is for employer, employee, and government contribute. And then the rest of that, and then you can see that on CSMBS, Civil Servant Medical Benefit Scheme for government, actually not employee, because government employee now belong to the Social Security scheme. And the rest of that is on population covered by Universal Health Coverage Scheme. So actually in the year when we start in year 2001, we have in pilot in 6 provinces for universal coverage scheme. We start in 6 provinces and be the one who joined the team, research team, to research on what should be done and what should not be done for UC. But unfortunately, this is politics. Government cannot wait until we finish our research. After we set up the research, less than 6 months, government announced nationwide. They said that because the people in other provinces, they just would like to enjoy with the UC scheme. They said that why only 6 provinces need not to pay anything, while the rest of that have to pay. Think politics, right? In that year, then the government announced nationwide. So this is on historical development on payment method. You can see that for the Social Security scheme, used to be inclusive capitation for outpatient and inpatient, and next, for the year 1995, adjusted utilization for capitation payment, and then later 2001, adjusted for risk, right? For civil servant medical benefit scheme, right? And now actually for the Social Security, for inpatient care, now they use capitation and DRG. We see SMBS used to be free for service, for inpatient and outpatient, and later cannot control payment to be demand side control and to fee schedule and DRG. For UCS is capitation and DRG adjusted global budget. This is cost containment. Capitation is cost containment mechanism. Global budget, they say DRG, but DRG weighted with global budget, meaning that they control cost containment. Because the National Health Security Office are the biggest purchaser. When we start UC, they use purchaser-provider split. The money is not allocated, not paid to the Ministry of Public Health. It's paid to the new agency that is National Health Security Office, right? Per capitation. And then they use DRG with global budget and capitation. You can see that in this graph, majority of the CSMBS has a greater proportion of members age 60 up like me. I'm over 60, but I still be count in the CSMBS. UC actually has a greater of children, and most of them are the poor and near poor, right? And most of them live in the rural area. This is in providing universal health coverage increases demand and utilization. Remember, we changed from supply side mechanism to be demand side mechanism. And that's why we have enormous of for demand for healthcare, more than 3 times compared to before we start UC. And this one is, you already know this skill. So right now in Thailand, we have healthcare purchasing in CSMBS, Social Security, and UC. This is health, welfare, and insurance system in Thailand post National Health Security Act in the year 2002. You can see that CSMBS governing agency is Ministry of Finance. Social Security is Social Security Office, but actually is under Ministry of Labor. And National Health Security Scheme is under, the governing agency is National Health Security Office, right? And Ministry of Commerce, they do for traffic accident victim insurance and for private health insurance are under Ministry of Finance. What about the payment? See, you have this on payment in different, maybe I do not have time, but we have fee schedule, DRG, and with the health prevention and promotion, payment by fee schedule and by project. And this is on, next on performance, quality monitor or audit, CSMBS, none. Social Security, they do have annual quality audit. UC, they have audit, they have KPI system and claim review. For performance-based payment, only for Social Security, yes. If hospital, they be able to be accredited with hospital accreditation, they will be paid more, about almost 100 per head. But managed health program, vertical arrangement with separated contract is pre-authorization and patient, right? And we have disease management program for high cost or access to ARV and DM. So this is on the remaining, just summarize. Civil servant medical benefits scheme since 1980 covered about 8% of population by general tax, non-contributory, and use some of reimbursement. Social Security scheme since 1990 covered 18% payroll tax, third-party contribution, and capitation, and DRG right now. Universal coverage scheme covered about 76% of population, the biggest one, funded by general tax, non-contributory, capitation, and global budget, and DRG. So you can see on this is core business for UCS in National Health Security Office. They do monitoring and evaluation, do for IT infrastructure, for law and regulation, for human resource management and human resource development, or public relations and administration. So this is funding for UC. Source of finance is a tax-based finance. Pooling fund from general tax and close-end budget. Capitation and with the global budget is a close-end budget, right? And then no direct contribution. General principle of budget estimation is per capita budget. And data availability is on administrative database, hospital financial report. And policy direction is increase access, standard protocol, and new benefit package. So UC payment is mixed. I do not have time, but this one is in detail. And you see, this is UC benefit package. It's very comprehensive, right? Comprehensive. They have only negative list, very few. The rest of that is automatically be included in benefit package. You can imagine close-end budget, but open-end in terms of benefit package. This is the problem. And that's why they start the process of benefit package development in UC, Manit, right? And he is in high tab. After 2008 and onward, right, at the arrival of high tab, the health technology assessment for clarification of new benefit or change payment method for specific intervention is start, but not entirely. This is our remaining problem. Enabling factor for achieving UC, you must have strong political support. You must have health system capacity already in place. And we have lesson learned from predecessor from a previous of the prepayment scheme. We linking evidence to policy decision, mean that we have integral relationship among researcher, reformists, and politicians during economic crisis. And then we have UC scheme cover the poor, half belong to Q1 and Q2, right? Significant increase in utilization more on OP than IP, right? And this is remaining, right? We must reduction in the incident of the success is reduction in the incidence of catastrophic illness and impoverishment for medical bill. This one that they achieve. But how can they continue UC like this one? Because they use tax base, right? Remaining challenge is equitable distribution of health infrastructure and human resources, or harmonization of health insurance scheme for Social Security Scheme, CSMBS, and UCS in terms of benefit and payment methods in order to improve equity and efficiency of the system. We have problem challenges on quality of care because we paid by capitation and urbanization. Primary care in urban setting has not yet improved for public side. Population share in urban setting is growing. So one problem is long-term financial sustainability of the country, because the country is facing rapid population age. We are going to be like called aging population very soon, or aging society, and completely like on the aging society. NCD limiting diseases, elderly age over 60 years will be 25% in the year 2030, 5 years from now. And service utilization rate of the elderly is 2.3 times of the general population. And this is our problem. You can see, I give this now for the research, the reference, but this is, I took some slide from the Plan for National Health report. I work with this from the report on National Public Health Insurance Reform Plan, Phase 2, by Professor Pilom Kamon Ratanakul, the chair of the subcommittee, and this one is by the government, by the Prime Minister. I was one of the committee on national health system reform by that year. And then after that, if you interested in reform for UC, then you can, maybe if you want to ask, can ask me about that. So we have this is a group, working group for 4 group. This is health financing projection. You can see this. Huh? health expenditure, total government expenditure, in the year 2018, about 20% will jump to 25.5% in the year 2037. Almost double or triple every, and that is tax-based scheme. So what should be done? This is that we would like to must have essential package. What we mean by essential package is National Health Insurance Reform goals, SAFE. S, sustainability. A, adequacy. F, fairness. E, efficiency, right? And this one we use that in order to move our reform. So you can see that we have to let people understand equality and equity. The first that is you might mean that they be subsidized, right? For the rich, the poor, the middle income, the same. But this is equity. You need not to subsidize the rich. The rich need to pay, right? If they be able to pay. But only the poor, you need to subsidize more. If you are going to look at equality, then you cannot be able, because we have limited budget, we cannot even be able to provide enough services for the poor. With this plan, it come to, for my research, you see Social Security and CSMBS. We think that we must have a core package, essential package, the core package, and then later we can supplement with private health insurance. So this is the way that in the future we can harmonization of major public scheme with the core. And then up on that is on supplementary, is a voluntary public insurance scheme or supplement with private insurance scheme, right? In this is on the way that we have with the package, supplementary package 1, supplementary package 2, and essential benefit package. That is the same for all schemes. And this is for what we mean by supplementary, complementary, essential package. Private health insurance in Thailand we see as supplementary, not complementary, supplementary only. Yeah, I finished. And then this is designing the benefit package framework for promotion, prevention, primary care, hospital care, long-term care, and palliative care for pregnancy, child, teenager, adults, and old age. Look at that, health literacy. When we start, you see, we forget about the principle of public health is health literacy. So we must consider that one. And this one we can group in primary care cluster and hospital care. And this is the end. The payment, we start from activity-based payment, input-based payment, right? Input-based payment. And then we, and from this we call Thailand 1.0, activity-based payment, input-based. To capitation-based payment is output-based. To diagnosis-based payment, like DRG. And next, Thailand 4.0, we will perhaps on value-based payment or others. That is ongoing. Thank you so much.
Thank you so much, Professor Siripen, for the wonderful presentation.